So most people, when they hear the word cirrhosis, I feel like they immediately think of two things, right? Drinking too much and total liver failure.
Yeah, that's the classic assumption.
You're
Absolutely right.
right. But, as we're going to see today, our sources revealed that assumption is missing, like the actual fascinating reality of what this disease really
Oh,
is.
completely. It's totally misunderstood.
So, welcome to the deep dive. Today, we are taking this big stack of medical literature, pathology research, and historical texts, and we're aiming them straight at the pathophysiology of cirrhosis.
Sounds intimidating, but it's really a compelling story.
Yeah, exactly. Our mission for you listening is to take this heavy, intimidating medical term and unpack it from the absolute ground up. We're exploring the intricate cellular drama behind it because cirrhosis is actually this incredible and, well, often tragic story of the human body's own wound healing process just going completely rogue.
It really is. I mean, it fundamentally changes how you view the organ. Cirrhosis isn't really a single disease in the traditional sense.
Mhm.
It's what the sources call a final common pathway,
A final common pathway. Okay, so meaning what exactly?
meaning it's the liver's stereotyped, like programmed response to being injured over and over again for years.
Yeah.
And this happens completely regardless of the weapon used to injure it.
Oh, wow. So it doesn't matter what the cause is.
Exactly. Whether it's a virus or metabolic stress or alcohol, the liver reacts the exact same way every time.
That is wild. I definitely want to get into the microscopic mechanics of that reaction, but looking at the history in our sources, it seems like we actually have to start with how we first defined it.
Yeah, we really do. Because the history is kind of crazy.
It is because the way the medical community first started talking about cirrhosis had absolutely nothing to do with how the disease actually works.
No, not at all. We basically have to go back to 1819 to understand that blind spot.
1819. Okay.
Yeah, so the word cirrhosis was actually coined by this French physician named René Laennec,
Wait, Laennec, didn't he invent the stethoscope?
the very same guy.
Yeah.
Yeah. So in his famous treatise on auscultation, he was describing autopsies he had performed on patients who, historically had been really heavy drinkers.
Okay.
And when he examined their livers, he found they were shrunk, hard, and covered in these really distinctive yellowish tan nodules.
And he just named the entire disease category after that specific color.
Pretty much. I mean, he used the Greek word kyrhos,
Yeah.
which literally just means like tawny or orange yellow.
That is just, I mean, it's wild to think one of the most significant diagnoses in internal medicine is essentially just a color swatch.
Yeah, it's literally just a color because that nodular discolored surface was the most visually striking feature to the naked eye,
Yeah.
right? So that became the name.
But he had no concept of the cellular mechanisms or like the blood pressure changes happening inside that organ.
None whatsoever. I mean, he was describing texture and a color palette. And the crazy thing is, for over a century afterward, cirrhosis remained purely a visual morphologic diagnosis.
So doctors were just looking at it and saying, yep, it's orange.
Basically, a pathologist would look at a liver on an autopsy table or on a slide and say, yes, that pattern is cirrhosis. But the biological why, like who was building those nodules and why the liver changed color, it remained a total mystery.
Wow. Over a century.
Yeah. It wasn't really until the mid-20th century with researchers like Toshi Aruto in Japan in 1951 and later Hans Popper that medicine finally connected the visual pathology to actual cell biology.
Okay, so let's look at what modern medicine discovered when they finally got past that tawny color.
Right.
What exactly is cirrhosis structurally? Because the sources are incredibly adamant that we stop calling it just like a scarred liver.
Right, yeah. The strict modern definition actually requires 3 simultaneous changes to happen in the liver
The
tissue.
3 changes. Oh.
Yeah. And if you have all 3, you do not have cirrhosis. So first is diffuse fibrosis, which is just a widespread scarring.
Right.
Second is nodule formation. That means the surviving liver cells clump together into these abnormal, disorganized spheres as they, desperately try to regenerate.
Okay, so scars and clumps. What's the third?
The third, and this is the most critical piece, is the distortion of the vascular architecture.
Vascular architecture. Explain that part a bit more. Like, what does that actually look like inside the liver?
Okay, so the liver is normally organized into these really beautiful, efficient, microscopic hexagons called lobules.
Hexagons, got it.
Right. And blood flows in from the outside edges of the hexagon through these things called portal triads, and then it filters cleanly through the liver cells to the central vein in the middle.
Okay, so outside in.
Exactly. And that central vein carries the clean blood back to the heart. But cirrhosis, completely scrambles that relationship.
It scrambles it.
Yeah, the scar tissue builds up in a way that just chokes off those pathways, completely permanently altering the physical relationship between the inflow and the outflow.
So if simple fibrosis, just like regular early stage scarring, is like putting up some really ugly wallpaper in your house,
Uh-huh.
cirrhosis is more like a botched renovation where somebody accidentally poured concrete down all the plumbing and ventilation shafts.
That is, yeah, that's exactly it.
Like you literally can't have cirrhosis without a wrecked plumbing system.
That's a highly accurate way to visualize it, honestly.
Yeah.
And that concrete plumbing analogy leads straight into one of the biggest misconceptions we see in the sources,
Oh, really? Which one?
that cirrhosis is an architectural diagnosis. It is not fundamentally a functional one.
Wait, I have to push back on that, though.
Okay, sure.
Because if my house's plumbing is full of concrete, the house absolutely does not function. Like, I can't live there. How can you separate the architecture from the function?
I know, it sounds counterintuitive, but it's because the liver has a biological trait. Your house definitely doesn't have an immense, almost unbelievable functional reserve.
Functional reserve, meaning it can just keep going.
Exactly. Liver failure, which is when the organ actually stops making proteins or filtering toxins, that is the functional diagnosis.
Okay.
But you can have the architectural diagnosis of cirrhosis for years, sometimes decades, while the liver still does its job perfectly well.
Really? Decades.
Yeah. We call that compensated cirrhosis. The building's original plumbing is a labyrinth of concrete and dead ends, but the sheer volume of surviving liver cells in those nodules means the water is still somehow running out of the faucets.
Wow. That is incredible. But that brings us to, I guess, the cellular drama happening inside those walls. If the liver's architecture is being replaced by concrete, who is pouring it?
Right. We have to find the culprit.
The sources outline this fascinating biological cascade, starting with the initial injury. Walk us through that.
So the cascade begins when the liver takes damage. Let's say a virus like hepatitis B or C attacks the liver cells, which are called hepatocytes.
Hepatocytes.
Or perhaps it's chronic metabolic stress from excess stored fat, or even genetic conditions that cause, like, toxic copper buildup.
So any kind of damage.
Right. And when those hepatocytes die from the stress, they don't just disappear quietly. They burst, or they send out these desperate distress signals.
Which wakes up the liver's resident security guards, basically.
Exactly. The liver actually has its own dedicated population of macrophages known as Kupffer cells.
Kupffer cells.
Yeah. And they basically patrol the microscopic blood channels. When a Kupffer cell encounters the debris from a dead hepatocyte, it activates. And it starts releasing these powerful inflammatory alarms into the surrounding tissue.
Just blasting the alarm.
Pretty much. These alarms are chemical messengers called cytokines, specifically ones named TGF-beta and PDGF.
Okay, I want to pause on TGF-beta for a second because it pops up so much in the literature. What is a cytokine actually doing in this specific environment?
Think of a cytokine like TGF-beta as a chemical bullhorn.
A bullhorn, okay.
Yeah, the protein that one cell secretes to change the behavior of another cell nearby. So in normal temporary wound healing, TGF-beta tells the local cells, hey, we have a breach. Start laying down some temporary scar tissue to patch the hole.
But in the liver, that bullhorn is aimed at a very specific, totally fascinating cell. And this is basically the main villain of the cirrhosis story, right? Even though it doesn't start out as a villain at all.
No, not at all. You're talking about the hepatic stellate cell.
The stellate cell, yes.
So normally, these stellate cells just sit quietly in a microscopic gap between the blood vessels and the liver cells. It's an area called the space of Dissy.
Space of Dis, got it.
And their normal day job is incredibly mundane. They literally just store vitamin A in little lipid droplets inside their cytoplasm.
That's it.
That's it. In a healthy liver, they do almost nothing else.
So they're just like mild-mannered librarians hoarding vitamin A.
It's a very passive existence, yeah. But when those Kupffer cells start blasting the TGF-beta bullhorn because of chronic liver injury,
The alarm goes off.
exactly, the stellate cell is suddenly bathed in that chemical signal. And it undergoes this radical transformation called transdifferentiation.
Which is, from what I read, just a complete cellular identity crisis.
It really is. It changes its entire biological program. It drops all of its vitamin A droplets. It physically changes its shape. It actually acquires contractile machinery, meaning it can suddenly flex and squeeze like a smooth muscle cell.
Wait, it turns into a muscle.
Essentially, yeah. It goes from a quiescent storage unit to an activated myofibroblast. And its new primary obsession is to just pump out massive continuous quantities of collagen.
Which is the main protein in scar tissue.
Exactly.
So our quiet librarian suddenly drops their books, puts on a hard hat, grows massive muscles, and just starts frantically pouring concrete everywhere.
Yes. The caveat being that in an acute injury, say, like a single dose of a liver toxin, that construction worker behavior is actually helpful.
Oh, because it patches the damage.
Right. It patches the damage, and then the body sends a stand-down signal. The scar tissue gets dissolved, and the stellate cell just goes back to sleep.
Okay, so where does it go wrong?
The pathology of cirrhosis only happens because the injury is chronic. The virus or the alcohol, the metabolic stress, it just doesn't go away.
Ah, so the stand-down signal never comes.
Never comes.
So the rogue construction workers just keep pouring, the concrete keeps building up, and this leads to this really tragic irony that the sources highlight regarding how the liver interacts with our blood. Can you explain what happens to the sinusoids?
Yeah, this is one of the most devastating architectural changes.
Yeah.
So the liver is, at its core, a massive filtration plant, right?
Right.
To do that job, it uses unique, incredibly leaky capillaries called sinusoids.
Leaky capillaries.
Unlike normal blood vessels, which are sealed tubes, sinusoids have literal holes in them, pores. They're called fenestrations.
Wait, so the blood can physically spill out and, touch the liver cells?
Exactly.
Yeah.
The plasma needs to make direct contact with the hepatocytes so the liver can extract toxins, pull in nutrients from our food, and then secrete clean proteins back into the bloodstream.
Okay, that makes sense.
But as those activated stellate cells pour concrete into the space of DISI, they fill in those fenestrations. The leaky sinusoids become rigidly sealed tubes. We call this capillarization.
So the liver is essentially choking off its own blood supply while trying to heal itself.
That's exactly what's happening.
It's building a wall to protect the injured tissue, but in doing so, it isolates the surviving cells from the very blood they're supposed to be cleaning.
Yes, and the surviving hepatocytes are now trapped behind that wall. They are starved of oxygen and nutrients, so they start dividing rapidly in a panic, trying to replace the dying tissue.
And that's the clumps.
Yep. That frantic regeneration, bounded by walls of rigid scar tissue, is what forms those clumps, the nodules that Linux saw over 200 years ago.
Which brings us to the physics of the situation. Because we have this escalating pressure cooker now, right?
Yeah, massive pressure cover.
The architectural plumbing is choked with scar tissue, the leaky capillaries are sealed shut, and the whole structure is this messy labyrinth of nodules. Meanwhile, all this blood coming from our digestive system is trying to flow through the liver, and it suddenly hits a wall of biological concrete.
Yeah, and that collision creates what we call portal hypertension. And that drives almost all the severe clinical disasters associated with end-stage liver disease.
Portal hypertension, so high blood pressure in the portal system.
Right. The portal vein is this massive vessel that brings nutrient-rich blood from your intestines, stomach, and spleen directly into the liver. But because the liver's internal resistance is now astronomically high from all the concrete, the blood pressure in that portal vein skyrockets.
And blood, like water, is always going to seek the path of least resistance.
Exactly.
If it can't get through the liver, it's going to find a detour back to the heart.
The problem is that the human body's detour routes were never designed to handle that volume or that pressure of blood. The blood gets forced backward into smaller, much more fragile collateral veins.
And this is where we start seeing those terrifying symptoms the sources describe. Let's walk through why they happen, starting with esophageal varices.
Okay, so because the blood is backing up, it diverts into the veins lining the lower esophagus and the stomach. These are normally really tiny, thin-walled vessels. Under portal hypertension, they basically balloon outward, becoming incredibly swollen and tortuous. Those are varices.
Wow.
And because they are so thin and superficial, if one ruptures, the patient experiences catastrophic, often fatal internal bleeding.
That's terrifying. And the back pressure also affects the spleen, right? Leading to splenomegaly?
Yeah, so the splenic vein feeds directly into the portal system. When the portal vein gets backed up, the spleen physically inflates with trapped flood, like a water balloon attached to a blocked hose.
Oh, wow.
A normal spleen is roughly the size of a fist. But in severe cirrhosis, it can grow massive, and it starts trapping and destroying healthy blood cells in the process.
Then there's ascites, which I think is a symptom many people might recognize visually as, like a severely distended abdomen. What's the mechanism there?
It's actually a dual failure.
A dual failure? How so?
First, you have immense hydrostatic pressure pushing outward on the walls of the blood vessels in the abdomen because of all that backup.
Yeah.
Second, remember that the liver's factory function is failing. so it stops producing albumin.
Albumin, what does that do?
It's a protein that acts kind of like a sponge to keep fluid inside the blood vessels. So with high pressure pushing fluid out and no albumin to hold it in, liters of fluid literally weep out of the organs and pool freely inside the abdominal cavity.
Liters of fluid.
Liters. It's incredibly uncomfortable and dangerous.
And because the blood is bypassing the liver entirely through those detours we talked about, it's not being filtered either.
No, not at all. And that leads to hepatic encephalopathy.
Encephalopathy, so affecting the brain.
Exactly. Toxins that your liver would normally clear, like ammonia, which is produced by your gut bacteria, they now flow straight to your brain.
Oh, no.
Ammonia is highly toxic to brain cells, so it causes severe confusion, personality changes, and eventually it can lead to a coma.
All this body-wide mechanical failure is stemming from that one microscopic stellate cell pouring concrete.
It's all connected.
It's mind-blowing. But there is one detail in the sources regarding these detours that absolutely blew my mind. It's a physical symptom called caput medusae, the head of Medusa.
Oh, yeah. It is one of the most striking physical exam findings in all of medicine.
The sources describe it as visibly dilated, snake-like veins radiating outward from a person's belly button. And the biology of why it happens is wild. The body is actually reopening a closed fetal structure.
Yeah. The umbilical vein.
Wait, so a vein from when you were in the womb?
Exactly. When you're in the womb, your mother's oxygenated blood flows to you through the umbilical vein, which goes through your belly button directly to your developing liver.
Right.
But shortly after you were born, and the cord is cut, that vein collapses. It basically turns into a useless solid cord of connective tissue called the ligamentum teres.
Okay, so it's closed for business.
Totally closed. You haven't used it since before you took your first breath.
But decades later, under the desperate hydrostatic pressure of cirrhosis,
the pressure inside the portal system becomes so immense that the body physically forces that dead fetal vein back open.
it forces it open.
Yes, it tunnels back through the scar tissue of the ligamentum teres just to find a release valve. The blood flows outward to the abdominal wall, engorging the superficial veins all around the navel, and that creates that Medusa head appearance.
That is just...
It is a profound, incredibly desperate plumbing hack just to keep the blood moving.
It sounds incredibly bleak. I mean, you have fetal veins bursting open, varices threatening to rupture, the architecture turned to concrete. For decades, this entire process sounded like an absolute death sentence.
It really did.
But the modern medical literature in our sources reveals a massive paradigm shift in how doctors view this diagnosis today.
Huge shift. Because for most of the 20th century, the absolute dogma taught in medical schools was the one-way door.
The one-way door.
Yeah. The prevailing wisdom was, once the liver reaches the stage of architectural cirrhosis, it is completely, irreversibly, permanently scarred. The only cure was a transplant.
But the sources indicate that door swings both ways now. What changed?
The major breakthrough that really forced hepatologists to rethink the dogma was the cure for hepatitis C.
Oh, okay.
Yeah, around 2013, medicine introduced direct-acting antiviral drugs like sofosbuvir. And for the first time, we could reliably, rapidly cure patients of a virus that had been destroying their livers for decades.
You completely remove the weapon.
Yes.
So the Kupffer cells stop sounding the alarm and the stellate cells stop getting the bullhorn signal.
Exactly. And researchers started tracking these cured patients using a new diagnostic tool called elastography. Specifically, a machine called a FibroScan.
A FibroScan? How does that work?
Instead of relying on a biopsy to look at the cells, a FibroScan bounces a mechanical shear wave through the liver and basically measures how fast that wave travels.
How does a wave tell you about the scarring, though?
Well, think about tapping a block of soft gelatin versus tapping a solid brick.
Right, sure.
Sound and shear waves travel much faster through dense, stiff material. By measuring the wave's speed, the machine calculates the stiffness of the liver in a unit of pressure called kilopascals.
Oh, that's clever.
It took Lianic's visual guess from 1819 and turned it into an objective physical measurement of tissue rigidity.
And what did those kilopascal measurements actually show in the cured Hep C patients?
They dropped significantly.
Really?
Researchers found measurable regression of fibrosis. It turns out that if you remove the insult, the liver can partially undo its own scarring.
Wow.
Our rogue librarian construction worker can actually take the hard ad off, drop the tools, and enzymes in the liver can start slowly dismantling some of the concrete.
But our sources highlight a very active, ongoing debate in the medical community about what that actually means.
Yeah, because the skepticism comes down to function versus architecture again. The debate is the architectural cirrhosis truly reversible, or is the liver just becoming less bad?
Less bad, meaning what?
Meaning, yes, the stiffness scores improve on the FibroScan. Yes, some of the diffuse fibrosis clears up. But even when patients are cured of hepatitis C, or they lose significant weight to relieve metabolic stress, they still remain at a highly elevated lifetime risk for hepatocellular carcinoma.
Liver cancer.
Right.
So the body might, tear down some of the ugly wallpaper, but the underlying concrete plumbing is still mangled enough to cause problems.
Exactly. The structural damage isn't entirely wiped clean. The vascular distortion often persists to some degree, meaning portal hypertension complications can still arise years later.
Right.
But moving from a fatalistic one-way street to knowing we can meaningfully regress the damage and halt its progression, that has fundamentally changed hepatology.
And speaking of fundamental changes, we have to address how the medical community talks about this disease culturally, because the word cirrhosis goes way beyond biology and the public consciousness.
Oh, absolutely.
For the longest time, the general public assumed cirrhosis strictly meant one thing: late-stage alcoholism.
Yeah, it is a classic case of a scientifically accurate association hardening into a really damaging, inaccurate stereotype. Alcohol toxicity absolutely does cause cirrhosis. But the assumption became that a cirrhosis diagnosis implied alcohol abuse.
And the sources show how much harm that stereotype caused. You had patients with genetic liver diseases like hemochromatosis or autoimmune hepatitis dealing with immense stigma.
It was terrible for them.
And doctors themselves might under-investigate non-alcohol causes simply because they anchored their diagnosis on the assumption the patient was, hiding a drinking problem.
And that stigma obscured a massive demographic shift. Today, in high-income countries, metabolic issues are the fastest-growing driver of cirrhosis.
Not alcohol.
Right. It is tracking perfectly alongside the epidemics of obesity and type 2 diabetes. The fat accumulates in the liver, causes chronic inflammation, and triggers the exact same stellate cell cascade we discussed.
Which led to what the medical community called the Great Renaming of 2023.
Yes. For years, doctors called the metabolic version of this disease AFLD, non-alcoholic fatty liver disease.
AFLD, right?
But in 2023, international hepatology societies formally changed the terminology to MASLD, metabolic dysfunction-associated steatotic liver disease.
MASLD. It's a bit of a mouthful for the average patient, honestly. What was the core reasoning behind changing a globally recognized acronym?
Well, they realized that defining a disease by what it wasn't, non-alcoholic, was inherently flawed. It was confusing for patients who might, consume a moderate amount of alcohol, and it still carried a subtle stigma.
Oh, that makes sense.
By changing it to MASLD, the medical community shifted the focus entirely to the actual metabolic drivers causing the cellular injury: obesity, insulin resistance, and dyslipidemia.
Dyslipidemia being the abnormal levels of lipids, like high cholesterol or triglycerides in the blood, which fuel that metabolic fire.
Precisely. Words matter immensely in medicine. Changing the name changes how primary care doctors screen for the condition, how research gets funded, and importantly, how patients internalize their own diagnosis. It's a crucial move toward precision over rigidness.
It really brings into focus how far our understanding has evolved. Let's recap this journey for you listening. We started in 1819 with René Laennec naming a major disease purely for its tawny color, with zero insight into the mechanisms.
Yep.
Then we zoomed all the way down to the microscopic space of DISC, watching the quiescent stellate cell drop its vitamin A and transform into this concrete-pouring myofibroblast, literally choking off the liver's leaky fenestration.
And then we follow the blood flow outward, right, to see how that wrecked architecture creates a dangerous pressure cooker of portal hypertension, backing up into the spleen, inflating esophageal varices, and even forcing a dormant fetal umbilical vein to tear back open.
Which is still just wild to me.
It's incredible. And finally, we saw how modern tools like elastography shattered the one-way door myth, offering real hope of regressing the scars, while the medical community actively works to erase decades of cultural stigma.
It completely changes how you view an organ we usually take completely for granted. But I want to leave you with a final provocative thought inspired by everything we unpacked today.
Okay.
We talked earlier about the liver's enormous functional reserve, its ability to endure immense damage before it ever actually
Right,
fails.
the silent compensation.
Exactly. That compensated cirrhosis can be totally silent for years, maybe decades, while the plumbing turns to concrete. And generally in biology, we think of resilience as a superpower. We celebrate the human body's endurance.
We usually view the lack of pain as a sign of strength.
Right. But in the case of the liver, is its incredible ability to suffer in silence actually its fatal flaw? Think about it. If the liver complained earlier, if it hurt intensely on day one of the damage, the way like a sprained ankle swells up and forces you to limp immediately, maybe we would stop the cellular damage before the entire architecture collapses.
Oh, immense.
If only the liver could give us a clear, painful signal from the very beginning instead of silently compensating until the pressure cooker explodes. It's something to think about the next time you marvel at the human body's tolerance for abuse.
That is a really fascinating perspective on biological resilience. Wow.
Well, that's all for this deep dive. We'll catch you next time.